Hey everyone, welcome. Thanks for joining. I think we'll wait a few more minutes to let everybody join. I think some people are going to be coming in from after the awards, but really excited to see folks interested in this session. Hey, everyone who's on, just welcome. It looks like the Scotty Awards presentation is still ongoing, so we'll wait a little bit more before we get started. But thanks for being here. Really excited for this session. Welcome to everyone who's joining. We'll give just another minute or two for folks to continue to join, and then we'll get started. All right. Well, welcome everyone. It's so great to see everyone who's logged on. Welcome to the workshop on palliative care, which we have subtitled Improving Quality of Life for You and Your Family. I really just want to express gratitude. I think it can be a little bit nerve-wracking for coming to a workshop that's called palliative care. We know that not a lot of information, not a lot of accurate information is always out there about what palliative care is and what that means. So we're really hoping to provide some more information today about palliative care, when and how to use it, what it involves. To get us started too, I just wanted to also introduce another person who's here from my team, Olivia Tigre Niramura. She's here with her video on. She works with me in our palliative care team at Stanford University. So she may be answering some questions in the Q&A or in the chat. I do want to encourage you. I want this time to be as helpful for you as possible. So if there are questions you have about palliative care, what it is, anything, please feel free to start putting those in the Q&A area or to put them in the chat. I want this to be interactive and as helpful as possible. My name's Grant Smith. I'm a palliative care doctor at Stanford Healthcare at the Stanford School of Medicine. And today we're going to be talking about this thing called palliative care and how it can improve quality of life for you and your family. And just to say that we'll be kind of talking about this idea of quality of life. And I think when we hear that term, it means a lot of different things to different people. And some of these pictures are things that you might identify with as quality of life, spending time on your hobbies, spending time with friends, family, being in nature, being with your loved ones, being there for big life events, weddings, birthdays, Lots of things that are included in quality of life that aren't pictured here. But this is really kind of the goal of palliative care, is to improve quality of life. And as a doctor, I certainly know that illnesses can have a big impact on quality of life, whether that's how you're spending your time, if that's in medical facilities, if the things that you're able to do are changing, if you're needing to spend a lot of time caregiving. Those are all big impacts on quality of life. And the whole goal of this thing called palliative care and the medical specialty of palliative care is to try to get people back to that good quality of life that they were enjoying, or try to optimize or maximize life and living, and life to make it as good as it can be, even when there's a difficult illness going on, even for that individual or for the one that they're caring about. I thought I might start by sharing a little bit about myself, just so you know a bit about my background. This is a photo of me my first day at Stanford as a faculty member. And I wanted to tell a little bit about how I got into this field of palliative care to sort of start explaining it. But I got interested actually in this topic, this area in college. I was taking a class that was on kind of aging in America and talked a little bit about even end-of-life experiences in the United States. And for me, that was really mind-blowing that, end-of-life care, taking care of elderly individuals, taking care of seriously ill or very sick people in the United States was something that we don't, and certainly didn't do a very good job of. And yet that's something that we know that all of us will experience, people we care about, our loved ones will experience. So that really opened my eyes to this topic of thinking about how do we take care of each other and of patients, of individuals when they're feeling really, really sick or dealing with a difficult illness. Later on in my career, I had a year that I spent actually in Tanzania in Africa with an OBGYN. And this was before I was going to medical school. And I was asking him for advice. And I said, how did you pick your medical specialty? How did you decide what to go into? And one of the things he told me was, Grant, I went into a field where there was a piece of care that I was pissed about. I was upset, angry. I felt like it wasn't being done very well. And I really carried that piece of advice with me as I went into medical school and on through more training. And it ended up being kind of this area of care, serious illness, care for those who are elderly, care around the end of life that I felt a little bit angry about. I feel like wasn't being done the way I would want to be cared for. I'd want my family to be cared for. And that's what really got me interested in this concept, this type of care called palliative care. As I went on in my training, I saw doctors doing this type of work. And I thought, gosh, that's really what I thought being a doctor was all about. So we'll talk more about the specifics of that. But that's how I got interested in this thing called palliative care. On a more personal note too, I'm really excited to be here at this event focusing on dementia and caregivers for people with dementia. And the center photo on the left is my dad's father, my grandfather, who died from complications of dementia. That's me and my brother in the middle underneath my grandmother. And then on the right is a picture of my maternal grandmother, who also died from complications of dementia. So just wanted to share that this is very personal, and caring for individuals living with these illnesses is really important. I've shared a bit about what's bringing me to this space today. I was curious if anyone would feel comfortable either in the chat or by unmuting themselves. What brought you today? And maybe in particular, what brought you to a workshop called Palliative Care? Anyone feeling willing to share? Yeah, Jana, I see you on video raising your hand.
Yeah, my husband is 69 years old and has frontotemporal dementia, behavioral variant. And I guess I've just kind of been curious about at what point in the disease is the appropriate time for like a referral. I've asked his primary care doctor, and because my husband's active, he walks, but he does need monitoring and everything, but when is the appropriate time to kind of, I feel like I'm pushing for it because I don't want to wait to the last minute and need it and not have things set up.
Thanks so much, Janet. Yeah, I really appreciate it. I think we'll definitely spend some time talking about kind of when and how do you get connected to palliative care. And you can let me know if we haven't fully kind of answered that question by the end too. Anyone else feel open to sharing?
My mom's currently living with dementia, and it runs in our family. In fact, she's at Stanford quite often. So, and I guess the initial big questions that we're constantly facing and having to reevaluate is that at what point does that quality of living, how is that challenged by different people's opinions of what that quality ought to be via pain management, via let them eat whatever they want, versus those of us as caregivers, that, hey, yeah, if I let her eat whatever she wants, I'm going to be dealing with the bowel issues and all kinds of other suffering down the road, even though in that moment, brother, sister, family member who's feeding them the sweets or the chocolates or whatever, that becomes a challenge. And then that leads into the actual, the bigger question with regards to the care, the quality of life, and what can even become detrimental and even lead into the palliative even sooner than later. And then my only other experience was figuring out some hacks and things in the early days of dementia back in the day before Bredson and all of the different, I was actually on the phone with a lot of you. So with our family history and figuring out hacks and things that can actually help alleviate a lot of those issues. And we bounced my mom back off of hospice one time. I used hospice palliative care to actually bring her back to a quality of life and extend longer. And she's still currently living, and she's one of the happiest Alzheimer's patients I've ever met and worked with. So just, how to make use of these things to serve that individual's ideal of quality of life are some of the issues and challenges and things that keep coming up.
Well, thank you so much, Alan, for sharing. There's a lot of great stuff there to unpack. And I know they've given us a very short amount of time for a big task. Thank you for those who put things in the chat. Continue to do that and connect with each other in the chat. I may move us forward a little bit just so we make sure we get some good baseline information down. And I want to make sure we have good time for questions too at the end. But I think I see some questions in the chat coming up too. And just wanted to share, this is kind of what I was hoping we could talk about today. And I think it will address some of the questions that have already been mentioned, is just, what is this thing called palliative care? When and how do you get it and access it? What's the difference between palliative care and hospice? I know that is one of the biggest questions that we get doing kind of education work. And if we have time, there's a few kind of tips from my team members that I'd love to share with you if we get to that. But let's talk a little bit about what is this thing called palliative care. And maybe you can think in your own mind or put in the chat too, like what comes to mind when you hear the term palliative care. And I think there's a lot of information out there on the internet. There's a lot of misinformation, but be interested to see what people think of when they hear palliative care. I don't have this slide in, but if you Google image search palliative care, you see a lot of hands holding each other. And certainly that's good and great. I think our team, we're happy to hold hands physically, literally, and metaphorically. And I hope by the end of today, we can recognize that we can do a lot more than that too. We have a lot more to offer than sort of just that. One of the things that I think is helpful to recognize about how palliative care is different is we do have a little bit of a different philosophy. And I think Alan was really getting at this in his comments. A lot of us really think about seeing the person beyond the disease, and even a turn of phrase as simple as, this is a person living with dementia versus a dementia patient. So it's a little bit of a turn of phrase, but I think it reflects the mentality that we try to take as we're thinking about how to help someone, that this is a person first and they happen to have this illness. And we really try to focus on their personhood as the center of our care. And not just the person, but no matter what the illness, but I think especially with illnesses like dementia, it's really the family, chosen family, caregiver, whatever it might be, is sort of the center of our care. And we really acknowledge that a difficult illness like dementia affects not just the body, those physical symptoms, Alan was alluding to some, whether it's constipation, diarrhea, agitation, hallucinations, all those things can be physical symptoms, but there's also this psychological piece, the sadness, the anxiety, the worry, both for the individual and the caregiver. For some people, spiritual concerns about like, why is this happening? How do I find meaning in what's going on? And then practical things. Do you need a DMV placard? Do we need to get a wheelchair? Those practical things. I think what I'm trying to say here is that our team really understands and tries to respect the fact that all these aspects of life can be affected. And we try to help out in addressing each of these. So palliative care is a little bit different than going to see, for example, the neurologist that might focus really on the brain and neurologic issues, or a cardiologist or a cancer doctor that focuses on a specific disease or a specific part of the body. Palliative care really focuses on the personhood and the whole individual. So we don't have a specialty in terms of a particular illness or part of the body, but try to think about that holistic care plan. Palliative care is a little bit different too, in that we do work as a team to make sure we're trying to address all those different aspects of someone's life that could be affected. So the doctors and nurses might help prescribe medication to help manage some of those physical symptoms. We do a lot of what Alan was referring to about thinking about future medical decisions, are weighing the burdens versus the benefits of kind of any intervention, a hospitalization, blood sugar monitoring, diabetes management, diet. All those things come with like a burden and a benefit, and try to help weigh, how do we think about what plan makes sense to honor the person that we're caring for. Our social workers help with providing emotional support, sometimes can do some one-on-one counseling, help to talk with caregivers about the stresses they may be feeling, thinking about those practical things like, is there medical equipment needed? Are there financial concerns? What type of help can we get through the insurance company? What type might we need to pay for, but can we help get you connected with an agency to help make that a little bit smoother? And then most palliative care teams also work with chaplains or spiritual care providers who also can help support that aspect of healing, coping, offering prayers, blessings, and exploring kind of how an illness or a caregiver role has made an impact on someone's spiritual journey or coping. So that's a little bit about how palliative care, I think, is different from some of our other specialties of medicine. And I just wanted to provide kind of one consistent definition that is really how our field likes to be defined. And that's really that palliative care is specialized healthcare for people living with a serious illness. And we'll talk more about what classifies as a serious illness. And the type of care is focused on providing that relief from both the symptoms and just the stress that can come from a tough illness. Like we said from the beginning, the goal is to improve quality of life for both the individual with the illness and for their family, friends, chosen family, caregivers. And as we talked about, it's provided by a specially trained team. And we work together with other doctors. So that's an important note, that you don't give up anything to come see a palliative care team. You keep your primary care doctor, you keep your neurologist, your dementia specialist. And we really provide an extra and often can be an essential layer of support. And then we're going to talk more about what Janet brought up too. But as a definition, palliative care is really based on the needs of the individual and not on a specific prognosis or time frame. And it really can be appropriate actually at any point in a serious illness and at any age. And for individuals who have even curative illnesses. We can help someone get over a bump in the road or get them through treatment that might be causing some difficult challenges. So let me unpack a little bit of these kind of phrases that we've mentioned. We talked about living with a serious illness, and I'm going to focus kind of on dementia here, but certainly it can be other life-limiting illnesses like cancer, end-stage heart disease, lung disease, kidney or liver disease. But we see patients who have all different forms of dementia, ALS, Parkinson's disease, other neurologic illnesses. And I think that we can be especially helpful when there start to be more complications or more challenges with the illness. So maybe that's recurrent or repeat urinary tract infections, recurrent pneumonias, repeated hospitalizations, aspiration, so food going down the wrong pipe, bed sores, falls, behavioral challenges, even just becoming more dependent, needing more help at home. Those are some of the times and types of things that is really common for us to talk about in a palliative care visit with someone who's living with dementia. We talked about relieving symptoms and the stress. And again, we mentioned some of these, but I think some of the common symptoms that can come up in dementia can be pain, constipation, behavioral agitation changes, hallucinations, depression, anxiety, fatigue, low appetite, weight loss. And then definitely for the caregivers too, the stress that comes with that, the grief, the bereavement, even if we sometimes call it anticipatory grief, the bereavement or grief over the loss of what could have been or what we had hoped would have been for the later years of someone's life. And we talked about kind of this holistic approach, and that's really how we try to go about relieving these symptoms. So I often think pain is sort of an easy example here, that we know that pain, there's this physical component where the nerves send signals to the brain to say there's an ouch, but we also know that there's biology of the brain sending signals back down to the nerves to help interpret and regulate those signals. And that really has to do with both like psychological, spiritual coping, integrative techniques. We think that for complex symptoms like pain, we need complex solutions perhaps that leverage all those different ways of coping. And so that's why we work as a team and how we try to help manage symptoms. We talked about sort of helping with medical decisions, and that can include things like thinking through what we call advanced healthcare planning, which is that thinking about how to make decisions or what types of decisions we might need to make if an individual isn't able to communicate their wishes. Sometimes that can involve doing things like an advance directive or a living will or living trust. These are all words that are sometimes thrown around for the same type of idea. In California, where I'm based, we have something called a pulse form, which is another form of kind of putting your wishes in writing. And then we do an awful lot of what Alan talked about, and we've been mentioning weighing these different treatment options, weighing the benefits versus the burdens of whatever it may be. I know that you all know there's a million different decisions that can come up. And we often are trying to weigh that. And we're there to really walk alongside that journey to think about that with you and to work with your other doctors to help with that. I know I've said a lot in a pretty short amount of time, so maybe we can just pause and see if there are any questions that have come up in the chat or in the Q&A. Olivia, I might just ask you any questions you saw in the chat that we should bring up right now?
Hi, yes, one of the questions that I'm seeing are if we could touch on the differences, which usually it does get touched upon, but because it's a shorter session, the differences between hospice and palliative care. There seems to be some folks that do know the difference about palliative care, but if maybe we could touch on that a little bit more. And then the question of at what point do we, does someone seek a referral, kind of going back to what Alan had initially said in his response at first.
Great, thank you. Well, we'll make sure we get to those. And maybe we can start with that first question about kind of when the right time is. I actually I'm seeing a comment in the chat, Brandy saying dementia care is palliative care. And I really agree with that. And, that is part of why we also have this kind of phrase that palliative care can be appropriate at any age or any stage. And, in addition to those symptoms I talked about, these were some of the things that I thought about might be a good time to think about asking for a palliative care visit. Even right off a new diagnosis, sometimes that can hit really hard, and there's a lot of emotions that come with that. And thinking about maybe planning ahead, what do we need to think about now while things are relatively maybe really good? Maybe the individual can really help think about what they would want in the future. What conversations should we have now? We talked about those increasing complications. I think for caregivers, if you're feeling like at the end of your rope, it's time for some more help. We're a team that can sort of help think about where do we get more help. I think sometimes people come to us wondering about, can I keep my loved one at home? What are options if we're feeling like the care is too much? What can we do to maximize supports? Our team, our social workers, that's one of the things that we're happy to help think about. And if you're feeling like that things are moving towards more of that end of life decision making, we have a lot of expertise in thinking through those questions too. I think that my biggest comment that I want to leave you with is that we really can decide together, and this is common at the end of all of my visits with patients, we have like a conversation about how much we should follow up and when to follow up. So I hate and I don't want the individuals I care for to feel like they have to hold all of that. We can decide together. Maybe it's a one-time consultation early in the course of the illness to bring up a lot of questions that are helpful to think about. That's okay. Maybe things are getting pretty intense and we need to see each other every month or even every few weeks. That's okay too, and that can change over time. So typically we can titrate up or down what is needed based on the needs of the individual. I'm going to skip over this for just a little bit, but to get palliative care, really the best way is to still ask your healthcare team for a referral. And I think there are a lot of ways to do that. Sometimes we hear, I don't know exactly what to say or how to ask. And even just saying some of the language we've used today, I wonder if palliative care might be a good extra layer of support for me. Would you be willing to refer me? Or maybe there's something specific you want help with. I'd like to get help with my father's agitation at home. I'm wondering if palliative care could help. Or use me and this talk as an excuse. Hey, I went to this talk at this conference. The palliative care doctor said that this could be helpful. I'd like at least to go for a one-time consultation. Will you send a referral? I recognize it's hard to sometimes have to advocate, and I'll recognize that some of my colleagues, a lot of medicine is still catching up. Palliative care is relatively new. So feel empowered to advocate. Say, I'd like to meet with them at least once. And you can acknowledge too that you recognize that this isn't just for people at the end of life. If you get that resistance from your provider, like, hey, I'm not worried necessarily we're at that stage, but I just want some help with some of the other things going on to get some help with. I want to take a moment to go back to Brandy's comment, which was really excellent, that dementia care is palliative care. That's really true too. We're not here to replace the primary care doctor, the dementia care neurology doctor. It is wonderful if they meet all of your needs. No worries, that's okay. It's kind of like, I think in some ways like a heart doctor. The primary care doctor can do a great job of managing high blood pressure. But if the high blood pressure doesn't respond to the first two medications, there's now other organs getting injured from the high blood pressure, maybe it's time to see the heart doctor, the blood pressure specialist, to get that extra help. We're kind of like that service, that if you feel like, what you're getting from your other doctors isn't quite enough, or the problems are getting pretty complex, we're that extra layer of support that can be added on. So I hope that helps answer a little bit about that timing question, and feel free to put more questions in the chat if there are still some lingering questions. I know we're coming up on time, so I'll go through a few things real quick. I saw a question in the chat about who pays for palliative care. It typically is covered like other medical specialty clinics. So if you go see the neurologist, you might have to pay a copay for that visit. That might be true for palliative care, but in general, it should be covered like other medical specialties. I will say that palliative care can be different at different institutions, like who makes up the team and how often or frequently they can see someone. So you do have to ask around a little bit, but rely on sort of your local providers. And I'll share a national resource for looking for palliative care teams and programs based on your zip code before we end too. I myself even was trying to look into this, and I just went to my insurance portal and looked under the search for providers. And if I typed things like palliative medicine, palliative care, hospice and palliative medicine, that got me the search results of the people I know who do the work I do that came up under my insurance plan. So I would recommend you can sort of use that search tool to look for providers too that contract with your insurance. Like we mentioned, a referral from a primary care doctor, a specialist, or even a hospital team or an emergency room, those are great ways to get connected to a palliative care team. All right, let's get to the palliative care and hospice discussion. I know that's a big question. And this is a simple picture, but I do like it a lot. It helps me like keep it in my head about really the difference and the similarity. Think of palliative care as like the umbrella term, where we are kind of broader than hospice in that we can see people at any age, any stage of an illness, whether they're going to be cured of their illness, they're not going to be cured, they're getting treatment, they're not getting treatment, whatever. Hospice really is the subset of palliative care that does focus more on end-of-life care. And when an individual has a likely prognosis that's around 6 months or less. So, it sort of overlaps with palliative care in that they also are working to help make someone's quality of life as good as it can be, but it is a little bit more sort of time and prognosis bound than palliative care. And I often think about hospice kind of in these three ways, that it's a philosophy of care, it's an insurance benefit, and then there's kind of this set or bundle of services that come with it. So as a philosophy, I often am telling patients that I think about hospice as a really good fit when comfort of the individual is the #1 priority. And that priority is kind of so strong that you're feeling comfortable and okay, maybe deferring some things that might help someone to live longer. But when you do that calculation about the burden versus the benefit, the burden of those interventions are almost always beyond the benefit it would offer. So that really at a place where we're accepting that someone is facing the end of their life, and the goal is really for them to be comfortable and to not do too much that's going to kind of artificially prolong their life. That's when hospice, I think, can be a really good fit. As a reminder, hospice can be delivered where the patient or where the individual is most comfortable. So if that's at home, most hospice is administered at home, but they can also follow a patient into a nursing facility if that's where they would be most comfortable. It is an insurance benefit that's covered. It's really the insurance side that provides the eligibility guidelines that to be eligible for hospice, that two doctors assess that more likely than not, the individual has a likely prognosis of 6 months or less. So that's kind of the time piece and the end of life piece that gets wrapped up into hospice. And I think one thing that is maybe a little bit less relevant to dementia care is that hospice typically doesn't cover interventions that are meant to really reverse the underlying serious illness. So in oncology, this is really clear in some ways that like they won't cover ongoing chemotherapy or immunotherapy. In dementia, it's a little bit less clear that unfortunately we don't have a curative medication for dementia. So there's not as much of kind of that coverage, but is always kind of a good conversation to have before enrolling in hospice. There's definitely a list of services that hospice provides. They also work as an interdisciplinary team. It can be home-based care. They have this 24-hour call line, so you can get help after hours, and they can send a nurse to the home to check in on the individual if that's needed. They provide medications that are needed for comfort and medical equipment if that's needed, like a hospital bed or bedside commode, wheelchair, those sorts of things. Well, let me pause here because we just have 10 minutes left, and I want to make sure we're answering the questions that have come up. So let me pause and just see if there are any other questions in the chat that we haven't been able to address. And feel free, if anyone has a question, you're welcome to unmute as well. Olivia, did you see anything come through the chat that we haven't been able to get to just yet?
I haven't seen too many questions. I see a lot of interest in just being able to share this back with the organizations. I've seen some connections through nurse practitioners talk about their experience and trying to find the right language to, when speaking about palliative care. Maybe if some, for example, Leah, if you want to maybe expand a little bit, it would be great to hear from you.
Yeah, so where I work, we have what we call BRGs, business resource groups, and I'm on the board for our caregivers business resource group, and our community members have been bringing up dementia and end of life, palliative, just a lot of those types of topics lately. So we actually have several of our board members attending different sessions today within this. So, and some of us have actually dealt with it in our own lives, but we try to find information and bring it back to our community members, and even to our employer as a whole, trying to expand our caregiver benefits, just because that's such a huge segment. And if we can provide benefits for our caregivers, that increases quality of life for, you know, all of us, the people we're giving care to, us as employees, you know, their retention just across the board.
Yeah, thanks so much, Leah. And I wonder too, Olivia, we could also put our palliative care email in the chat in case someone wants to connect afterwards to share even more resources. I've got a slide with some resources that has our website on it too. So I'll be sure to share that. I'm seeing in the chat, Tracy had just mentioned that one thing I struggle with is how hard it can be to target when kind of hospice would be appropriate with that 6-month prognosis. And yes, I just to affirm what you're saying, Tracy, I think that is really challenging, especially in dementia care. Hospice does have some guidelines to help physicians with that. I think, though, it's often a conversation and really about that philosophy of care. And I think sometimes it's helpful to know if you feel like the philosophy of hospice is a good fit, you can be on hospice for 6 months and go longer. As long as that sort of condition stays in that likely prognosis, even if it ends up being longer, you can stay on. And sometimes people do what we call graduate from hospice. Alan sounds like he's had an experience with that, hey, it worked really well. Like they were comfortable, their quality of life got better, and they got better, and they lived a lot longer than we thought. That's okay too. So it's always good for a conversation. Alan, I see your hand up.
Yeah, I was going to say there are some other guidelines that allow you those exceptional rules. Like with my mom, she had lost an exceptional amount of weight, and that made her eligible for the hospice. Now, I knew that that had to do with the caregiving experience. We didn't have professionals at that time, and I was having to deal with some other health issues myself, having beat cancer. So, by the way, caregivers, take care of yourselves. Really important. But yeah, that became an exception to the rule. And then the other thing that I'm interested in, because when I brought hospice in, I essentially had to do what you're describing is use them as palliative care. I had to use them in a way that I said, okay, I know what we can do to bring her bounce back, and she's not ready to go yet. And that was clear. I would love to see that integrative approach from the very beginning. Had palliative care been available when my mom first was, when I first recognized the symptoms that run in the family, I could have had palliative care approach from an integrative standpoint, and we could have had the asthma and allergies addressed that are contributing factors to the dementia. We could have had the sleep apnea addressed that were contributing factors to the memory fog and all of these things. There's so many other things. And it's a blessing that my mom, being a nurse, she said, I don't want the label of the Alzheimer's. I don't want the label. And I said, okay, Mom, but are we willing to do all of those things like you would for yourself as a nurse? She goes, yes. Then let's look at the diet, the nutrition, the meditation, the exercise, all of these components. Let's look at things that can impact memory and fog. So let's get allergy tested. Let's find out how your breathing is. Let's find out all of these things. And that actually brought her from a moderate, almost advanced level of cognitive decline back down to mild, and it slowed the whole process down for a good 3-4 extra years. And to this day, she's still living with the Alzheimer's at 12 plus years. I think she's going on a record for being out there with it. And she is the happiest, most active, joyful individual. It's like having all those things in place, and the things that she got to let go of were all those worries and stresses and all the negative that most people have to challenge and go through with the person there and the loved one that they're caregiving for. And
Lily and Pamela.
So
and,
it can be done.
Of course, shout out to our sponsors who made those awards possible. AZI as.
Thanks so much, Alan. Well, I'm getting a note from the organizers that we should wrap up in the last 2 minutes. But thank you all so much for coming. Are there any other last minute questions? Feel free to put them in the chat. I will just quickly show you our resources slide. And I believe this slide deck should have already been uploaded into the lobby for this session. So feel free to take a look at that. I know you're seeing kind of these pro tips from me and my colleagues. Feel free to take a look at those. But we do have our website here. There's a couple other websites from some of the big national palliative care organizations. I think has a lot of good educational material. Our website, I feel like we have pretty good educational material as well. And then very important, the bottom website, getpalliativecare.org, is where there is a national database of palliative care organizations, and you can put in your zip code and say, I'm looking for hospital-based, office-based, or home-based palliative care. We're a growing field. We're not everywhere, but this is where you can search to find the closest team for you and start asking your providers if you feel like it'd be helpful. So thank you all so much for coming. It's brave to come to a session called Palliative Care. I want to acknowledge that. I hope you can be advocates and spread the news about this service. We're here to try to help and work with you. So thank you so much for your excellent questions and participation.